All right, so we know that peritoneal disease is spread of malignant cells along the peritoneal surfaces, including omentum and mesentery. And the common sources are GI malignancies such as colorectal, gastric, appendiceal, or pancreaticobiliary cancers, or gynecologic cancers, especially ovarian cancers that includes fallopian tube and primary peritoneal cancer, or other malignancies like breast, lung, mesotheliomas, some sarcomas and lymphomas. And we should also remember that if it's peritoneal disease from carcinomas, it's carcinomatosis. If it's sarcomas, it's sarcomatosis or lymphomatosis. And usually peritoneal disease is considered like end stage of any malignant journey. That means conventionally it was treated as a poor prognosis and treated with a palliative intent, with the exception obviously of ovarian cancer, where even patients with peritoneal disease routinely undergo surgery. Now, let's talk a little bit about HIPEC. HIPEC is hyperthermic intraperitoneal chemotherapy. And usually it's given after cytoreductive surgery. The idea is to directly target cancer cells in the peritoneum. The surgery will take care of bulk of the disease, but always tiny bit of cancer cells may remain behind. And we want to target those. So if you instill chemotherapy directly into the peritoneum, it will have better reach and higher local concentration than systemic chemotherapy. Also, heat enhances the cytotoxic effect of the drug. And essentially, the idea is that it would help eradicate residual microscopic or tiny bit of disease. It can be done with closed approach, where there's inflow and outflow cannula, or open approach. Both have their advantages and disadvantages. Open approach is supposed to give a little bit better spread of the agent, better reach. Closed approach has a little bit higher pressure and supposed to act a little bit better, but both the approaches are okay. Now, combination of cytoreductive surgery and HIPEC offers the potential to treat peritoneal disease with curative intent instead of palliative approach, like I mentioned before. And this is an example of ovarian cancer, but there's data showing improved survival rates with HIPEC. One of our oncologists was actually editor of NEJM. He used to say whenever he gets a new paper, he puts a finger between the two curves. If he thinks there's a good separation, he was obviously joking, they would accept the trial. Anyway, so while there is improved survival, there are also complications like bowel complications, infections, kidney dysfunction, or anemia. This is the protocol used at Brigham and Women's Hospital. We use mostly cisplatin-based HIPEC. The inflow temperature is around 42 degrees or 41.5 degrees. We really don't need all these details for radiology purpose, but again, this is just to show an example of how it might be done. And other drugs might also be used, like mitomycin C. So when it comes to colorectal cancer, there are two main studies. This is the older one, that was the first one, and it was published in JCO. And that study compared systemic chemotherapy with or without palliative surgery versus cytoreductive surgery with HIPEC. Now, at the outset, you'll notice this is great. This was old study. You're proposing something new and important. But you'll notice a bit of a bias here, because one arm has with or without surgery, and the HIPEC arm had aggressive intent, cytoreductive surgery. They knew they were going to be aggressive about it and adding HIPEC to it. So there is a bit of a bias. But in any case, the results were great. 105 patients, they showed improved overall survival, 22 months versus 13 months. And then this is the more recent study, PRODIGE 7. And again, this is a randomized open-label phase 3 trial performed in France. They included patients with colorectal cancer with peritoneal disease, with good performance status, PCI of 25 or less. And those patients were eligible to receive systemic chemotherapy for 6 months. So they included 265 patients and randomized them between cytoreductive surgery with or without HIPEC. And all these patients had complete macroscopic resection or surgical resection with less than 1 millimeter of residual tumor. So something to keep in mind, these surgeries were pretty successful to begin with. There was very little disease. And primary endpoint was overall survival. So as you can see here, there was no significant difference in the overall survival. Hazard ratio, you can see it's almost 1. So basically, there was no difference. And you'll see these graphs are pretty much aligned. And on the other hand, the adverse events were a little bit more in the HIPEC group. So the conclusion was that CRS plus HIPEC offers no survival benefit and more frequent late complications. And therefore, they concluded that cytoreductive surgery alone should be sufficient in these patients. Now, one thing to keep in mind, all these patients, like I mentioned, they had pretty aggressive surgery, and almost all of them had complete resection or very tiny bit of residual tumor. That means the HIPEC didn't really have much to sort of act on, so to speak. So this might be one factor. Again, I'm speculating. I don't know for sure, but something to keep in mind. The first trial, there was a pretty significant difference between the control and study arm, but in this case, not so much. Now, let's talk about some other cancer, because here with colorectal cancer, there might be some, let's say, controversy, whether how helpful or how effective HIPEC is. Still, there is data that it's effective in other cancers. So let's explore something else, ovarian cancer. We know that there's evidence to support cisplatin-based HIPEC after interval cytoreduction after neoadjuvant chemotherapy in stage 3 epithelial ovarian cancer. This was the main trial in ovarian cancer, again, phase 3 trial, and it showed clear survival benefit, both in terms of progression-free survival and overall survival. Then this is a meta-analysis that was published just this year. Again, it showed PFS was improved compared to surgery alone because of HIPEC. And there was higher incidence of acute renal failure. What about recurrent ovarian cancer? What I mentioned earlier was at the time of initial treatment. What about recurrent cancer? Let's look at two studies. They both are multi-center phase 3 trials. Both included patients with relapsed platinum-sensitive patients. Both had cisplatin-based HIPEC. In one of them, primary endpoint was overall survival. The other one, it was PFS, progression-free survival. Our first study had 415 patients and showed better overall survival with HIPEC. And they also had more toxicities, which we cannot know. We already expected. The other study had 167 patients, and they showed no progression-free, no PFS benefit because of HIPEC. They did have slightly improved 5-year expected survival, but as you can see how they overlap. Basically, it was not statistically significant. And they had similar adverse events. So again, what this shows, there is some confusion. There's a lot we need to learn about HIPEC, its clinical utility, patient selection, the actual method of performing it. So we know something, we know it's helpful, but at the same time, we still have a lot to learn about it. So this Chicago Consensus Working Group suggested, or they recommended HIPEC, CRS plus HIPEC for 9 tumor types. Colorectal cancer, ovarian, appendiceal, gastric, and peritoneal mesothelioma have high-grade evidence. Now, with this trial that we just discussed, there may be some question about colorectal cancer, but there is pretty decent evidence about the other malignancies. With some sarcomas like DSRCT or GIST, or neuroendocrine tumor or breast cancer, the level of evidence is a little bit lower. But still, there is some encouraging data. So in all this, where does imaging factor? Role of imaging is focused on assessment of tumor location and burden, because that helps patient selection by assessing the likelihood of whether it's total or optimal cytoreduction is possible or not. It also allows surgical planning, and we'll give some examples of that later. In post-operative setting, imaging is useful to assess complications like ileus, bowel obstruction, or anastomotic leakage, or infections. And also, obviously, for surveillance, because now we are treating something, we want to make sure whether there's recurrence or not. And even without HIPEC, there is a role of imaging in assessment of peritoneal disease. And it's pretty similar. We need to help select patients and sort of help plan the treatment, because the prognosis in patients with peritoneal disease depends, one, on tumor biology, and then on peritoneal tumor burden. And imaging and that's what determines the management, whether a patient will get surgery, neoadjuvant chemotherapy, HIPEC, et cetera. And to sort of reach these decisions, to make these decisions, we need accurate mapping of the disease to guide surgical planning, and importantly, to avoid unnecessary surgeries. For example, if you know that patient will not have optimal cytoreduction, then maybe it's better not to perform the surgery and avoid the complications. So that's why assessment of sites and disease volume is important. And traditionally, PCI was assessed surgically. But now there is increasing reliance on pre-op imaging, and we are going to briefly talk about that later. And as radiologists, we need to understand the patterns of spread, the peritoneal spread, common sites of involvement, or blind spots to give accurate assessment. So when it comes to imaging, first thing we need to remember, imaging always underestimates peritoneal disease. CT is our workhorse. That's the modality we primarily use. And we know CT misses small or sheet-like implants. Like, for example, if it's a nodule like this, CT will be okay. We'll pick it up almost always. But if there are tiny nodules like this, or if you have plaque-like, sort of sheet-like involvement, CT will look almost normal. And when surgeon will go in, they'll be, well, surprised there's a disease in here. But now surgeons know that. They expect imaging to not pick up these plaque-like or sheet-like disease or tiny nodules. But as radiologists, it's important that we are aware of this. Of course, use of positive oral contrast is helpful unless there are calcified implants. MRI is increasingly used, especially in Europe, especially for ovarian cancer. It's really good at detecting implants along the small bowel serosa, pelvis, subdiaphragmatic recesses, hepatic hilum. Especially diffusion-weighted images increase the conspicuity of implants. PET-CT is mostly used for follow-up or extraperitoneal findings. It has both false positives and false negatives. We don't really use it in the primary setting. FAPI-PET is shown to have some promise. This image was shared by Dr. Vikram Lele from Jaslok Hospital. And PET-MR is promising, but it's not widely available yet. So as radiologists, we should know the pathways of peritoneal spread, and I'm going to very briefly talk about it. So disease spreads from tumor cells flow with the peritoneal fluid. So they start in the pelvis, right lower quadrant, along the right paracolic gutter, up into the perihepatic space or Morrison's pouch, and then down along the diaphragmatic surface, perisplenic region, down into the paracolic gutter into the pelvis. And you can follow a similar pattern when you're evaluating for disease. You can go up, start with the pelvis, right paracolic gutter, up into perihepatic, peridiaphragmatic region, and down on the other side. Also, the other approach, and you can use both of these, is to sort of look at this as a wheel and spoke pattern. In the first arc, you can look at the omentum, because that's a very common site of involvement. That's where a lot of the peritoneal fluid is absorbed, so a lot of the cells settle there and start growing. Then second line is the bowel. Look at bowel serosa. And then look at the mesentery and root of mesentery. One way or the other, it's important to have a systematic approach, because if you don't have that, you're likely to miss disease. Now, PCI, it's surgical. It's a distribution of peritoneal disease in 13 abdominopelvic regions. There are 9 quadrants, and then 4 regions, upper and lower jejunum, upper and lower ileum. And then based on the size of the implants, you give lesion size score of 1 if implants are really tiny, less than 0.25 centimeter, 2, 2.25 to 5 centimeter, and 3 if it's 5 centimeter or more, or if it's caking. And then so 13 regions, you get up to score of up to 39. And higher score means more likelihood of incomplete cytoreduction. So with this in mind, there are some sites that require special attention. But before we go into this, there's something else I want to talk about. Now, something very basic, implant. What's an implant? Implant is a lesion on serosa or surface of an organ. Do you see an implant here? There's one sitting on gastric surface. Now, this could happen on liver surface, spleen, bowel, wherever. There could be implants anywhere. The other thing is parenchymal lesion. That's a space-occupying lesion within the solid lesion that indicates hematogenous spread. Peritoneal disease is often a result of direct spill, sometimes through lymphatic channels, rarely hematogenous. But parenchymal lesions are always hematogenous spread, like for example here. Now, why am I talking about this? Because it's really important to distinguish between parenchymal lesion, that's hematogenous spread, from invasion from peritoneal disease, especially in ovarian cancer. Because in ovarian cancer, for example, if it's peritoneal disease, it's stage 3. Even if it invades the liver, like here, it's still stage 3, which means better prognosis. If it's hematogenous spread to liver, that's stage 4. Still, it's important to talk about it. Assessment becomes easy if you look at coronal and sagittal images. And once you see it, it's important to mention it in the report, because if nothing else, this may change the surgical approach, because this may require resection of the, wedge resection of the liver. That means different surgical approach, longer surgery time, longer anesthesia time. The surgeon needs to plan accordingly. Sometimes the invasion can be really large. This is still peritoneal disease, but with large invasion of the liver. So again, modified surgical approach. It's important to communicate this. Implants along the diaphragmatic surface or at the porta, they make complete cytoreduction challenging because it's not easy to access. So if there's a lot of disease along the diaphragmatic surface, we should talk about it. Or if you see disease along the porta or along the hepatic fissures, we need to mention it. And this is where diffusion really shines. Lesser sac implants are easy to overlook. Now, this is a very obvious example, big, chunky nodular disease, but sometimes there's a tiny bit of disease, stranding. When you're scrolling through the images, it's easy to overlook, so make sure to stop and look at it. Route of mesentery is, again, another problematic area, because that involvement is associated with a higher rate of suboptimal cytoreduction. And especially if there is such extensive disease, most of these patients will not go to surgery, because this is impossible to resect. The involvement of mesentery can look like thick sheet-like involvement or just thickening of the mesenteric folds. There could be nodules, or there could be this like clumped, diffuse, thickened appearance where all the bowel loops are clumped together. Obviously, this is the hardest because this is not going to be resectable at all. But they all are pretty hard. If there's retraction of the mesenteric root, or if this kind of appearance, again, this will make surgery really difficult. Extensive bowel involvement. Now, there's no definition of how extensive is extensive or what makes it unresectable. But typically, this requires discussion with the surgeon so that they can actually see it and make a decision about how aggressive they want to be. At our institution, typically 3 or more sites make it, like surgeons will typically not operate on that patient, because that will require multiple anastomosis, and that's just not a good idea. Again, patients with something like this, it's going to be really hard to achieve optimal cytoreduction. Pelvic sidewall, again, is important because the extent of pelvic sidewall involvement and the structures involved, they can impact cytoreductive surgery. Especially if the disease gets within 3 millimeters of the pelvic sidewall or the vessels, we should talk about it. Like in this case, this implant is sitting right abutting the vessel. And then speaking of vessels or like abutting important structures, we should also talk about whether when there are serosal implants or implants sitting on a vessel, it's really important that we communicate it. Why? Especially if the patient is going to receive any neoadjuvant therapy in colorectal cancer or in ovarian cancer. This patient received bevacizumab. Then at some point, patient developed a fistula with bowel, tumor bowel fistula. You see this big gas in the tumor. And then next time point, actually, patient had pseudoaneurysm of the iliac artery. And then a few days after this scan, patient had a massive bleed and died. So it's really important for radiologists to communicate serosal implants because they can lead to complications, especially if you're expecting the patient to start on anti-angiogenic drugs. Upper abdominal lymph nodes, another important site. Upper abdominal nodes or suprarenal retroperitoneal nodes, again, are associated with a higher rate of suboptimal cytoreduction. So if you see something like this, it needs to be in the report. And obviously, disease outside the abdomen. And that's where PET CT is very helpful, but obviously CT does the trick too. Epiphrenic lymph nodes deserve a special mention. They're often enlarged when there is peritoneal disease because that's how the lymphatic spread goes. And they are previously they were not often resected, but now increasingly resected transabdominally. And again, same sites are also sites of residual disease or sites of recurrent disease. And actually, Avinash's group has a really nice article in Radiographics about HIPEC, so I encourage everyone to read it. I just want to very briefly mention PIPEC. This is something else. This is pressurized intraperitoneal aerosol chemotherapy. It's basically aerosolized chemotherapy under pressure using laparoscopy. It's less invasive. Early results are encouraging, but of course, we don't have any long-term data. We need to learn more about it. And then just very briefly, future trends. I mean, there's photon counting CT. We are improving our ability to detect more confidently and accurately detect implants. Whole body diffusion-weighted imaging may have some promise. PET MRI, FAPI PET. And then we talked about how amount of peritoneal disease, the disease volume is important, right? So automated segmentation may help here. And obviously, there's so much hype about radiomics. Right now, we don't have anything concrete, but there are many, many studies going on about behavior of the tumor and how aggressive it's going to be and how it's going to respond to chemotherapy. So there may be more data coming on that. So in conclusion, HIPEC has the potential to treat peritoneal disease with curative intent instead of palliative. There are some controversies. We still have a lot to learn about it. But at the core, pathology, the sites involved, and the disease burden determine the treatment and outcomes. Radiologists can significantly influence the treatment choices and surgical approach. And it's important to report disease burden, sites associated with difficult or suboptimal cytoreduction, and sites that need altered surgical approach. Thank you.
Thank you, Dr. Atul. That was a very truly comprehensive and timely presentation. The session is now open for questions.
Do you want to come up to the dais? Thank you so much for that bird's eye view, I would say. So I'm actually a gynae-oncologist, so I'm probably the only surgeon in the hall right now. I'm not sure if there's any colorectal surgeon here. So if you look at this evidence, and if you look at the meta-analysis of HIPEC in ovarian cancer, this number actually far outweighs the numbers that we are seeing that we've published in ovarian cancer so far. So the meta-analysis that you put up on one of your slides, that only has 250 patients of ovarian cancer across 3 randomized controlled trials in the primary setting. And we do have survival benefit in that area. But HIPEC PRODIGE, of course, is an interesting twist, which brings us to the basis of how randomized controlled trials are anyway conducted. There is a small number bias, right? So we're treating lakhs of patients, but when you have 250 in a meta-analysis, we begin to wonder whether there is a real benefit, which is probably why still HIPEC is considered as to be offered in research setting or in trial settings, even though NCCN and your consensus groups do tell us to recommend it across to our patients. In our setting, we do lesser cases of HIPEC compared to maybe like EPIC, which is something that we give post-operatively, because for us long surgeries for 6 to 7 hours, as such, compromise outcomes, increase morbidities. So there is an additional morbidity of HIPEC. And until you actually go into the operating room and achieve optimal cytoreduction, the key word there is optimal cytoreduction. It cannot be a replacement for suboptimal cytoreduction. So I'm glad that in HIPEC PRODIGE, the cytoreduction was less than 1 mm. For us, it's anywhere between 5 mm and 1 centimeter even, so you are allowed a little bit more leeway. But many people go back thinking that HIPEC is a replacement for optimal cytoreduction, right? That's not the case. So that also acts as an important confounding factor. So the question is, if the surgeon's able to achieve optimal cytoreduction, do we really need HIPEC? And I'm talking for ovarian cancer, where there are more and more confounding factors now that have come up in terms of VEGF inhibitors, in terms of olaparib or PARP inhibitors for BRCA mutated. So we really don't know where to fit HIPEC. That is about the HIPEC story. But as such, to go one step further, we depend on you not just for HIPEC, but for achieving optimal cytoreduction. That is the most important point of view that radiologists offer to us, because like you rightly pointed out, if there are disease in certain sites, there is no question a surgical team will even think of going in for primary cytoreduction. But we know that when we have good imaging, good backup, and we know where exactly disease sites are, then we are confident of going in, and first step is optimally cytoreducing, and then comes the HIPEC. So
Absolutely.
Thank you so much for...
And that makes sense. And that's why HIPEC, it's not offered everywhere, and only even in centers where it's offered, not every surgeon does it, not on all patients. It's still very selective, and for good reason. And like, as you mentioned, it's really important to achieve optimal, complete or at least optimal cytoreduction. Otherwise, it's better not to operate. And that's where I think radiologists play the biggest role to say, okay, this patient is probably worth not operating. So all good points, agree.
Thank you, Dr. Atul. That was a really not only a bird's eye view, but a comprehensive lecture of what, as a radiologist, we have to tell the surgeon. I think that's very important in today's scenario, that you know what the surgeon or what the treating clinician needs to know. Thank you. And we are open for questions in the audience. If you have not put it up, it's fine. You can just stand up and...
So one of the things you said that when it comes to assessment of peritoneal disease, MR helps. So my point is, when it comes to mesenteric disease, especially like diffusion, though it is like, I believe it's good when it comes to mental deposits and all, but when it comes to mesentery, let's say jejunum per se is very bright on, diffusion because, and I'm not very sure, like, can we really comment about those small deposits along the serosal surface or, for a measurable disease, yes, of course, the CT also does a reasonable job. But diffusion, I'm kind of, because should we really recommend MR for peritoneal disease assessment?
That's a great point. So first thing, most of the studies are coming out of Europe from just a few centers. Most of it from the MROC trial, because now they have they have the optimized protocol. They're used to doing it. Like at our center, we do bunch of MRs, but still we rely on CT, just because this is not what we use MRI for. The more we use, we'll get better at it. That's one. So radiologist experience. Then having the right protocol or patient preparation is important. We don't routinely use antiperistaltic agents. But if you have to do it, you need antiperistaltic agents, because once bowel starts moving, you're not going to see anything. Then it's probably worse than CT. Often pineapple juice or something like that, that might also help increase the prominence of implants, especially on diffusion. So there are all these other factors. So radiologist experience, having the right protocol, and just like regional practices. Some places are doing it more and more, some places not quite as much. In the US, it's still not used as much as Europe. So, but yeah, all good points. And we are still learning like how accurate it can be. But data from those centers which are doing it regularly suggests that MRI has better accuracy than CT. But once MROC data comes out, I think we'll know a little bit more, because then they have hundreds of patients, multiple readers. So then we'll really know if it is generalizable or not.
So I just would like to add to Dr. Atul and also to your query. At my institute, we are doing ample of MRs regarding the peritoneum. As he said, first is the patients, second is complexity of the study. So your tech has to be well learned, what a surgeon, especially what a radiologist needs, and second followed by what radiologist is aware about, what surgeon wants to see. Second point, patient has to be well counseled that this study will go for more than 40-50 minutes. There are 3-station study, so most of the time what we do is we give antiperistaltic agent, we give buscopan, then mannitol mixed with pineapple juice, 1 glass prior to the study and 1 glass 20 minutes ahead. That's it. And followed by multi-B value imaging, corresponding ADC interpretation, manual interpretation, and if there is a sizable nodule more than 1 centimeter to 5 centimeter. See, any nodule more than 5 centimeter is well identified, whether it is in mesentery or anywhere else in the peritoneum. But between 5 mm to 1 centimeter or 1 to 3 centimeter is a catchy point where specific mesenteric folds are there. At that point of time, we focused on that individual nodule on the plane scan and ask tech while sitting beside him or any fellow of the team sitting beside him, go for a dynamic contrast. That changes the interpretation for radiologist also. We give more positive confidence to the surgeon, and surgeon is well aware with the relationship of central mesenteric vessels or the periphery. As ma'am said, they need complete cytoreduction as much as possible. So our main role is just like a military intelligence to tell them that these are the areas of infiltration, you go there and kill them. That is it. See, most of the time, these surgeries are not emergency surgeries. These are the planned surgeries. So sitting together with your surgeon, understanding their need, that is first point. Sitting with your technician to tell them what you need, and planning entire protocol, that is most important thing. Addition to that, you have advantage of a comprehensive department. You can take a plain CT cut or go check with the sonography probe whether there is mesenteric nodule is showing any vascularity, any specific thing is there or not. They are operating, go there in the OT and check. This is more of a learning process. We have crossed more than 95 MRs by now. But eventually, we were not that confident for the first MR, but now we are telling them ureteric implants are there. Very much sheet-like ureteric implants, we are able to tell them, and they are also happy. So it is more of a practice from my side, rather than going ahead and jump to the diagnosis.
So there is a question from the audience to the speaker. Should we use oral neutral or positive contrast?
So for CT, positive contrast is generally preferred. Unless there are calcified implants, in which case positive contrast can cause confusion. But for almost all of our cases, we use positive oral contrast.
Also to the audience, we conclude in our report, definitely we are mentioning all the findings in supramesocolic, inframesocolic, pelvic peritoneum, then PCI, but also we mentioned the pause segment where the P stands for PCI, A for ascites, with the volume of ascites, not in the ml, but the distribution, whether it is loculated or diffuse, then serosal implants, specific serosal implants, then U stands for U1 and U2, that is U is unresectable sites. U1 is complexity of the, according to the characterization of unresectability of the sites, unresectability of the disease, the complexity of surgery increases. So U1 and U2 is there. We have very good article in IJRA, Indian Journal of Radiology and Imaging, presented by Dr. Anuradha Chandramohan from CMC Vellore. So that is also one of the major points which you can incorporate in your reporting and or your understanding.
Yeah, and I did not talk about it, but it's sort of advised or recommended to use some kind of a template that systematically outlines the peritoneal disease sites so that we reduce the variability in reporting. So there are many synoptic report templates or just structured report templates available. So if you're not using it, it's highly recommended that you do.
Thank you. The fact that we are running out of time means there are a lot of good questions, and this has been a wonderful session. Thank you, Dr. Atul. A round of applause for him for a very, very well presented lecture. And with that, we'd like to close this session. Thank you all.
I would like to thank all the chairpersons for their valuable inputs. Thank you, ma'am, and thank you, sir.